Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
In today's episode, we're discussing surgical management of placenta accreta spectrum, or PAS, a condition which gynecologic oncologists often manage in conjunction with general OBGYN physicians and our MFM colleagues. Sydney, what are our learning objectives for today?
Our learning objectives are to define placenta accreta spectrum and its FIGO staging, to discuss the risk factors for PAS and how to diagnose it preoperatively, to review how to preoperatively prepare for management of suspected PAS, and to explore the options for management of PAS, including immediate cesarean hysterectomy, delayed interval hysterectomy, and options for uterine preservation and expectant management. Let's get started.
We wanted to start by reviewing the definitions and pathophysiology of placenta accreta spectrum. PAS, formerly known as morbidly adherent placenta, encompasses a range of conditions, including placenta accreta, placenta increta, and placenta percreta, which are all characterized by abnormal attachment or invasion of the placental trophoblast into the myometrium of the uterus. The etiology of PAS is thought to be a defect of the endometrial-myometrial interface due to a uterine scar or previous uterine instrumentation, which disturbs normal decidualization and leads to abnormally deep placental anchoring villi and trophoblast infiltration. This etiology aligns with risk factors for PAS, including prior cesarean delivery or uterine instrumentation, placenta previa, known Asherman syndrome, advanced maternal age, and multiparity. For patients with placenta previa and prior C-section, these risk factors are synergistic. The rate of PAS is 3% in patients with a previa and no prior C-section, 11% if there's one prior C-section, 40% with a placenta previa and 2 prior C-sections, and 61% with 3 prior C-sections. Finally, cesarean scar pregnancies, if diagnosed in the first trimester, have a close to 100% risk of developing PAS. The uterine scar theory doesn't explain, however, the small proportion of patients with PAS who lack these risk factors. As rates of cesarean delivery and uterine instrumentation in the U.S. rise, so do the rates of PAS. On a most recent assessment, the incidence of PAS in the U.S. was 1 in 272 births, a nearly tenfold increase compared to the 1970s.
PAS is associated with increased morbidity and mortality. Patients with PAS have a 1% perioperative mortality rate, with an 80% risk of experiencing maternal morbidity related to severe or life-threatening hemorrhage, prolonged hospitalization, peripartum infection, or less commonly, amniotic fluid embolism, among other complications. Ultimately, placenta accreta is a pathologic diagnosis and is graded using FIGO criteria. Grade 1, 2, and 3 describe placenta accreta, increta, and percreta, respectively. Grade 3 disease is broken down into 3A, with limited to the uterine serosa, 3B, including urinary bladder invasion, and 3C disease, with invasion of other pelvic tissues or organs. Because of the associated morbidity and mortality risks, antepartum identification of patients at high risk for PAS is crucial, as patients with PAS should be cared for in a level 3 or higher designated care system, with access to an interdisciplinary team, including expert neonatal, obstetric, critical care specialists, and a well-stocked blood bank. Known PAS also impacts delivery timing, with ACOG recommending delivery between 34 and 35 and 6 to mitigate the risk of severe hemorrhage with advancing gestational age. There are several modalities that can help identify a suspected PAS case prior to delivery. Maya, how do we reasonably predict which patients might have PAS prior to their deliveries?
Like you mentioned, having risk factors should raise our suspicion at the initial prenatal visit. Many suspected PAS cases are diagnosed in the second or third trimester using ultrasound, but if patients have increased risk for PAS, early ultrasound to ensure accurate dating is also crucial. Subsequent ultrasound timing is not standardized, but per ACOG, it's reasonable to perform ultrasounds for monitoring of suspected PAS at 18 to 20 weeks, 28 to 30 weeks, and 32 to 34 weeks. Features on ultrasound suggestive of potential PAS include vascular lacunae within the placenta, a loss of the hypoechoic zone between the placenta and the myometrium, decreased retroplacental myometrial thickness, especially if less than 1 millimeter, abnormal uterine serosa bladder interface, or overt or obvious invasion of the placenta into the myometrium, the serosa, or the bladder. Using Doppler on ultrasound can be helpful as it might demonstrate turbulent lacunar blood flow, which is another sign of PAS. MRI is another diagnostic modality that can be employed. If using MRI, findings concerning for PAS include dark intraplacental bands on T2 weighted imaging, bulging of the placenta or uterus, disruption of the placental uterine interface, and abnormal placental blood vessels. Unfortunately, imaging findings are not highly sensitive or specific for PAS, and MRI has not been really shown to have a higher sensitivity or specificity compared to ultrasound alone. In a systematic review, reported sensitivities were between 75 to 100% for MRI, with the pooled sensitivity reported at 94%. Specificity ranged between 65 to 100%, with a pooled specificity of 84%, and these were comparable to ultrasonography. Per ACOG and SMFM, MRI is not the preferred recommended modality for initial evaluation of PAS, but can be useful for difficult cases with a posterior placenta previa or a suspected per accreta, and it might be able to better visualize the lateral uterine surface more than ultrasound. The takeaway from imaging is, even when the suspicion is high, the placenta may deliver normally at the time of the planned cesarean delivery, and people without pre-delivery concern for PAS may have an unsuspected placenta accreta diagnosed at the time of delivery. Essentially, while planning can be helpful, we have to be ready for anything. In a delivery, clinical signs that can be suggestive of PAS include placental bulge, hypervascularity of the lower uterine segment overlying the placenta, and of course, lack of easy delivery of the placenta. While there are certain lab associations with PAS, none are sufficiently sensitive or specific, and so should not currently be used as part of the routine evaluation in the clinical setting. Sydney, you mentioned earlier that patients should be delivered in a level 3 or higher maternal care system. Aside from being in the right place, what other peri-delivery care can be helpful to prepare for these cases and to mitigate risks?
Thanks for asking. In June 2025, there was a clinical expert series published in the Green Journal about perioperative management of PAS via CHIST, written by Gilner et al., which supplements the existing ACOG guidelines for PAS. Being in the right place and having access to the right resources is crucial. Maximizing patients' preoperative hemoglobin is another way to mitigate risks of delivery. This can be done through optimization of nutrition, oral and IV iron, and can include pre-delivery transfusions if patients have significant anemia. It's important to understand the hospital system in which you'll be delivering and the available resources. Do you have cell saver access? Is there robust intraoperative POC laboratory testing? Do you have adequate stores of PRBCs, platelets, FFP, and other specialized blood products? Is there access to emergent consultation from services like interventional radiology and urology if needed? For planned and unplanned cases, understanding the landscape here is crucial. Comprehensive patient counseling is also very important. Patients need to understand the unpredictable nature of these cases and the limitations of preoperative testing like we've reviewed, and need to be informed about the risk of serious complications and death, especially with delayed delivery beyond 36 weeks. Other preoperative planning steps are less standard and we have less robust data. The use of planned preoperative ureteral stent placement was studied in a retrospective analysis of two large referral centers. In this review, 66% of the surgeries involved prophylactic ureteral stents, and patients in the stented group had a lower rate of GU injury at 28% versus 51%, even when controlling for confounders. Cystoscopy with or without stent placement can be a helpful adjunct prior to the start of a PAS delivery in high-grade cases where bladder involvement is suspected. The use of preoperatively placed catheters or balloons into the hypogastric arteries has been explored. These balloon catheters are typically placed and confirmed to be inflatable with resultant decreased blood flow through the arterial system preoperatively, and then the balloons are deflated until after the delivery of the fetus to ensure ongoing blood flow to the pregnancy. After delivery, the balloons are inflated intraoperatively. Similar techniques have been reported in several case series with mixed results regarding impact on EBL. Additionally, a small randomized trial did not show benefit to this technique. Given the lack of clear benefit and the risk of serious complications from catheter placement, this technique is not recommended as a routine part of preoperative prep for PAS cases.
Thanks, Sydney. Can you tell us about intraoperative tips and techniques for optimizing cesarean hysterectomy performed for PAS, whether planned or unscheduled? We're going to focus on the management once a PAS is suspected or discovered intraoperatively, as this is the point at which gynecologic oncology will get involved. If you're looking for resources on preparing for a suspected PAS case and initial intraoperative management strategies, like including the cesarean technique, there are excellent resources through ACOG or other podcasts like Creogs Over Coffee.
During the hysterectomy itself, there are some techniques that can be employed to manage blood loss. The internal iliac arteries, aka the hypogastric arteries, are the source of the uterine artery. As such, these can be targeted to decrease blood flow to the uterus and placenta. Hypogastric artery ligation has been described. If you're doing this, you must ensure that you ligate the hypogastrics distal to the posterior division branch point. Standard teaching is that the internal iliac artery branches into an anterior and posterior division 3 centimeters distally to the bifurcation of the common iliac into the external and internal iliac arteries in most patients. But in a quarter of patients, the branch point may be greater than 5 centimeters after the bifurcation of the common iliac. IR embolization of the hypogastric arteries and branches, multivessel embolization, can be done intraoperatively or done immediately after delivery. Muniz et al. Published a protocol in AJOG in 2023 which described intraoperative infusion of tranexamic acid after cord clamping, followed by hysterotomy closure, and then immediate UAE by IR. Compared to historic Accreta cases at their institution, this protocol was associated with a 33% reduction in blood loss, 1 liter average less, and a 51% decreased rate of blood transfusion, and a 5-fold reduction in need for use of massive transfusion protocol. The strategy was associated with longer operative times, increased need for general anesthesia, and equivalent postoperative complications and neonatal outcomes. We'll talk more about TXA in a bit. IR embolization can be useful, especially if a specific source can't be found or isolated. Another useful technique, especially if there are coagulopathies that need to be corrected or if there's diffuse oozing, is pelvic pressure packing. This can be left in for 24 hours with an open abdomen and ventilatory support if needed, while stabilizing the patient for surgical completion. Finally, aortic compression or clamping, including REBOA, which stands for resuscitative endovascular balloon occlusion of the aorta, is a heroic measure which can be done to control hemorrhage. This should be done below the renal artery. Risks associated with this intervention include arterial injury and thrombosis, a risk of mesenteric ischemia, and lower limb ischemia.
Another technique which can be employed in the setting of placenta accreta with surrounding organ involvement is a 2-hand posterior approach to the hysterectomy. This technique was described by Metsuo et al. In 2023. They first dissected the posterior peritoneum over the uterus and broad ligament, identified the ureter, then moved anteriorly to dissect the bladder and anterior aspect of the uterus. After the dissection was completed, they applied 2 hands, anterior and posterior, below the placental bed and provided gentle upward traction to delineate the uterine vessels and transect them lower than in a typical hysterectomy. This strategy was suggested as a way to avoid placement of clamps at the uterine isthmus and avoid tissue damage and inadvertent bleeding, and to improve visualization. You can also use a dry lap to pull up on the fundus instead of clamps, given the fragility of the uterine tissue during pregnancy and the risk of vessel shearing. If vessel damage occurs near the fundus or cornua, consider use of a fibrin-containing sealant patch like Everest or VistaSeal instead of suturing, which may just further worsen the bleeding.
We've talked about hemorrhage management before in our surgical complications and emergencies episode, and the same principles apply here. Avoid hypothermia, acidosis, and hypocalcemia. In massive transfusion, give products in a 1:1:1 ratio of PRBCs, FFP, and platelets, or some advocate a 2:1:1 ratio. Something specific to obstetric hemorrhage to remember from residency. TXA given as a 1-gram bolus, which can be repeated once at 30 minutes and again at 24 hours, at the time of hemorrhage identification has been shown to reduce mortality from hemorrhage and does not seem to significantly increase the risk of thromboembolic events. Hypofibrinogenemia is the strongest biomarker predictive of severe postpartum hemorrhage. If less than 200, there's a high likelihood of experiencing severe postpartum hemorrhage. If EBL is greater than 1500, redose your antibiotics. Postoperative care will depend on the patient's status. ICU care is not necessary as a routine measure, but should be used on an individualized basis. Postoperatively, have a low index of suspicion for consideration of return to the OR or IR embolization if hemorrhage is not controlled. Postoperative complications are a result of severe blood loss as well as intraoperative factors and include risk of organ failure, including Sheehan syndrome, infection, and unrecognized injury to the ureter's bladder or bowel. We've talked a lot about hysterectomy, which has been the standard of care. What can you tell us about alternative option for conservatively managing PAS? Is this something that is recommended?
The conversation around the optimal management of PAS is very interesting right now and is undergoing significant shifts. While it has traditionally been standard teaching that cesarean hysterectomy is the standard of care for the management of PAS, there is growing interest in alternative management strategies. Uterine preservation describes removal of the placenta and resection of the adherent section of the placenta without removing the uterus. Expectant management describes leaving the placenta either partially or totally in situ. Expectant management and uterine preservation have typically been less preferred due to a risk of delayed maternal hemorrhage and/or a need for subsequent surgeries, including hysterectomy, which can be catastrophic. A systematic review and meta-analysis was just published in AJOG in May 2025 by Hassami et al., investigating maternal outcomes after different management strategies for PAS. They included 16 studies in their meta-analysis, with a total of 2,300 patients diagnosed with PAS, of which roughly half underwent cesarean hysterectomy, and half were managed conservatively with either leaving the placenta in situ or with focal myometrial resection. They found that cesarean hysterectomy had significantly higher blood loss compared with expectant management and focal resection, and a higher need for transfusion than the focal resection group, but a similar transfusion rate to the expectant management or placenta in situ group. They also referenced a prior article which demonstrated an association between leaving the placenta in situ and risk of coagulopathy, which could explain the similar need for blood transfusion between this group and the CHIST group. Intraoperative GU injury were highest with cesarean hysterectomy, but rates of GI injury and thromboembolic events didn't differ between the groups. Rates of ICU admission were similar between the CHIST and local resection groups, but were lower in the expectant management group. Another meta-analysis published in the Green Journal in June of 2025 compared local resection to CHIST and overall had similar results. They also reported on the rate of hysterectomy after intended local resection and found that 15% of patients needed a hysterectomy ultimately. These meta-analyses echo existing work which has demonstrated a higher blood loss and transfusion rate in patients receiving C-HIST compared to conservative management. Finally, another meta-analysis published by Panayotescu et al. In 2022 evaluated rates of subsequent hysterectomy after expectant management, leaving the placenta in situ for PAS cases. They had a really variable rate of reoperation in the different studies, which ranged from 0 to 86%. So these strategies are still not the standard of care in the US, but are routinely employed in some other countries, and growing evidence continues to suggest the potential safety of these approaches in appropriately selected patients. Sydney, what about fertility after PAS?
We just briefly wanted to cover this topic as it can be very important for some patients. In one study published in 2010, 27 out of 91 patients desired subsequent pregnancy after conservative management, and 24 of them were able to go on and have pregnancies, with 21 giving birth after 34 weeks. 6 of 21 of those patients had recurrent PAS in their subsequent pregnancy. That's all we have for you today. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
Placenta accreta spectrum is defined as abnormal trophoblast invasion of part or all of the placenta into the myometrium of the uterus. It includes placenta accreta, placenta increta, and placenta percreta, from least to most severe, correlating with FIGO grade 1 to 3 disease.
Risk factors for PAS include placenta previa, prior cesarean section, advanced maternal age, multiparity, prior uterine surgeries or curettage, and Asherman syndrome. It is most often diagnosed by ultrasound in the second or third trimester, and ultrasonography is the standard of care. MRI can be used as an adjunct imaging study, especially for difficult cases like a posterior placenta previa or suspected percreta.
Preoperative preparation for these cases is key. They should be performed at institutions with a level 3 or higher maternal care unit that has access to an advanced interdisciplinary team and a robust blood bank. Delivery should be carefully planned, and preoperative management and prevention of anemia is key.
Immediate cesarean hysterectomy following delivery of the infant is the standard of care for routine PAS cases and is the most common approach. Delayed interval hysterectomy, uterine preservation with removal of the placenta, or expectant management, meaning leaving the placenta either partially or totally in situ, are emerging techniques which may be associated with decreased maternal morbidity, specifically hemorrhage and transfusion.
This has been another episode of Ready, Set, GYO, your source for all things Gyn-Onc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Justin Harold, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.